Thank you. Great. So there'll be a little bit of repetition because my co-faculty have mentioned much of what I'm going to talk about. We'll run through classification of bone defects, a quick slide on the causes, and we'll talk about how fixation and reconstruction are the twin pillars of bone loss management. I use the Anderson classification. It's an interoperative classification, and I think it's reproducible. So type 1 is a contained metaphyseal defect, tibia T1, femur F1. Cortical rim is always intact. You don't need augmentation. And here's a nice example where we've explanted, and all I've done is put a supplementary stem above and below. The type 2, tibia 2, T2, femur F2, contained or uncontained, that requires augmentation, but predominantly your soft tissue sleeves intact. Here's an example. It's a re-revision. When we explant for aseptic loosening, we reconstruct using a sleeve, no augment. We've got three-dimensional fixation in both zone 2 and zone 3. And then type 3 are the uncontained defects, major loss, metaphysis, cortex. They always need some form of reconstruction, and the ligaments almost always compromised. And here's an example of a re-revision going from hinge to hinge. So the causes, polywear, less so these days, but certainly if you have a practice that does revision, you'll see long-time patients coming back. Metallosis, instability, loss of fixation. Infection always comes with bone loss. The multi-revised knee, which is common in my practice. The trauma patients always give you a little headache. And sometimes a combination of everything, infection, multi-revisions, and well-intentioned previous surgery. But as I said, bone loss is a matter of reconstruction and fixation. The two go hand in hand. We talk about a zonal fixation technique, zone 1 being the joint surface, zone 2 the metaphysis, and zone 3 the diaphysis. And what you're trying to achieve is a two-zone fixation. So Kirk showed an elegant paper on zone 1 and 2 fixation. Most of my cases would be zone 2, 3. Zone 1, you want to establish stable cuts, augment when necessary, but your fixation in zone 1 is only cement. We have no other fixation in zone 1. You can augment with zone 2, 3 fixation, but zone 1 will always be cement. Zone 2, we're into metaphysis. We've got conical tapered surfaces above and below, and we need to reconstruct sometimes centrally and peripherally. And we can do that with sleeves, with bone graft, with cones for reconstruction. The fixation currently is only going to be cement or sleeves. Those are your two fixation options in zone 2. Right. Zone 3, the diaphysis. And we've got a long history of diaphyseal fixation, be it cemented or uncemented, and I don't think it matters which you choose as long as you do it well. Okay. There's a but. Most revisions require a combined approach of reconstruction fixation, and as I mentioned, we wanted to think about a multi-zone strategy where 2 out of the 3 zones are working for you. So that involves planning before you start, what instruments you're going to use, where are you going to reconstruct, where are you going to fix. Because if you don't, you're going to fail. And here's a failure, and it's nothing to do with the implant chosen, but was it done properly? Well, look, zone 1, there's a little bit of cement fixation. Zone 2, we've got nothing going on. And zone 3, short and narrow stems. Failure fixation and reconstruction is inevitable. So let me run you through some cases that hopefully will show how we can think about reconstruction fixation together. Here's a 65-year-old female, polywear. It's a T1 tibial loss, F2 in the femur. And we're going to reconstruct using sleeves and stems. Stem is probably a bit of overkill here, but that's my practice. Although having listened to Kirk, I may change. Male 60, aseptic loosening, T2 F1. This is a case from my colleague Andy Toms in Exeter. And he's used a mesh and bone graft to reconstruct. But his fixation is cement in zone 1 and 2 with a supplementary uncemented stem in zone 3. So he's thinking about reconstruction and fixation using zones to get a good outcome. Which brings me nicely onto cones. 2 examples here, one from Zimmer, one from Link. I use them both selectively. But cones are metal bone graft. They're a reconstruction option, not a fixation option. They give you something you can cement into. As soon as you mention cones, you're going for cemented fixation. And I'll give you a top tip here. only ever use full cones. And for that matter, only ever use tibial cones, whether you're doing a femur or a tibia. And my philosophy, if I've got to get any bone away to drop the cone in, I don't need a cone. Okay? So what I'm doing is filling a large defect with a reconstruction ring. And the last point to make is these hemicones, where you've got a large side and a small side, make no sense whatsoever. If you're going to fix, you want to fix where the bone stock is. So where the bone stock is, don't put a half ring, put a full ring. Maximise surface contact area, because that's where you'll get your reconstruction and bone ingrowth. There's an example here. Male 75, multi-revised, also multi-extensor mechanism revised, both of which have failed. He's infected, and really because of infection and extensor failure, I've said this patient, we're going to go for a two-stage arthrodesis. So I take everything out, put a static spacer, allow him to walk around in it to get used to a stiff knee. Hopefully we get rid of the infection. He came back and said, I can't live with a stiff leg. You know, will you do something different? So in this case, as a one-off really, we did a fixed hinge. So I haven't reconstructed the extensor mechanism at this point. I've used a cone in zone 2 to give me reconstruction rings, tibial cone, the femur and the tibia, and I've committed to cemented fixation above and below. I've gone for a fixed hinge because my extensors are weak. And there he is at this 4-year follow-up. I still haven't done the extensors. We talked about it, but given his scenario, I've decided to leave him alone. Here's another case, 73, infected, multiple previous revisions, major T2, F3 bone loss, and we're going to reconstruct here in a different method. I've gone for a fully uncemented sleeve and cone construct. So I'm using zone 3 with a longer stem than I normally would. I'm using zone 2 with a sleeve, and I'm hinging it because I need to get some constraint in there. And there's the 8-year review. And you can see there's bone growth behind, all around it, above and below, and it's worked. And I know the fixation's worked because she presented 8 years with a recurrent infection. Okay, so even your good results sometimes come back and bite you. One last case. This is what I did 2 weeks ago. Male 48, failed infected revision, polymicrobial. He's got a candida, proteus and a staph. We've got significant bone loss above and below. And we've gone for a big one stage here, using cones, tibia, femur and tibia. Cemented fixation, lots of antibiotics in the cement, and touch wood, at the moment, at the 2-week review, he's doing very well. Yeah, so same again, so cemented fixation. You can always salvage by just chopping away bone stock and putting a tumour in. This will work. Once you've given the bone away, you've given it away. It does not come back. And all you can end up doing is doing bigger and bigger implants. So I take my hat off to my tumour colleagues who do this. It is different in a tumour scenario to the multi-revised, previously infected, bad soft tissue envelope. So tumour prosthesis are a salvage, but not maybe a common salvage. To conclude, bone loss means reconstruction and fixation. Classification based upon contained and uncontained defects, and importantly, the soft tissues. If you're going to reconstruct, think of cement, augment, sleeves, cones, tumour prostheses, but also think of a zonal fixation technique so you can maximize what bone you have. Thank you.
Thank you, Dr. Rhidian. Dr. Mehta is here?
No, that was the talk I just did. That was me. I was masquerading as Dr. Mehta. One more talk.
Yeah.
Okay, so this is a really quick talk. Much as I love reconstructing, sometimes you get the stage where you're at the point of amputation, and can you go that one stage further? Probably you should think long and hard about it. Grammy's talk yesterday on when is enough is a great talk. And every single case I've got here probably should have gone through the enough is enough process. So when you're doing revisions, you need a modular system. Modularity comes in kits. It'll give you a range of sizes and shapes, but they are limited. And revision surgery is not cheap. With a custom, you're looking at your salvage, the end of the line. And for that, you can have unlimited sizes and shapes. You can change the surface. You can coat them with silver, with iodine. It saves you time in theatre, but there's a lag before you get there. You can't just turn up for custom. You've got to plan it. And they're not cheap. So if you look at modularity, this is a case from my first year as a consultant. It's a Stanmore hinge, it's been in for 15 years, major lysis, peripatetic fracture, and I treated him with a modular zone 3 stem, zone 2 sleeve, in a expectant manner. And you know, I got away with it. He did well, he healed, and I'm thinking I'm great. But for every case I've got away with, there'll be a case where I haven't. And that's where you've got to think about the exotic, the unique, the different things. And for the last 12 to 24 months, I've done a little bit of work with Link in a custom division. And I just want to run through a couple of cases showing how the process works and what we've been able to achieve. So, disastrous case, male, 73, multiple revisions, infection. I've gone for an implant arthrodesis as an avoidance to amputation. The problem with arthrodesis is it works best if you do it early with good bone stock. Once you do an implant arthrodesis over length, then your fixation's at a tremendous stress. And probably the best fixation you can get will be uncemented. In this case, I had an uncemented femoral stem, cemented tibial stem. The tibia loosened, became painful, and the infection came back. So we went for a two-stage strategy, retained the femoral stem, big spacer, left him in bed, left it all heal. But now I'm left with a very poor soft tissue envelope, a very small cavity inside. So we had a chat with the boys in Hamburg, and we came up with a custom plan. One was for a fixed hinge, I have no extensors, and the other was for a re-arthrodesis with extra small silver coatings. And these are the plans they send you. And they look at stem fixation, they look at augmentation, they look at constraint, and I had both options available. And we got away with a fixed hinge. We managed to put in what we planned, and the function's not great. He has no extensor mechanism. His leg remains short, but he finds it preferable to an amputation. I don't know whether he's right or whether we should amputate, but this is what we've done. Another case, disastrous case, female of 50, multiple infections, multiple organisms, multiple revisions, silver-coated, hinged implant, infected. So we take it all out, we space it, we let the soft tissue settle, we use that time to plan, and I'm now getting into the process. I'm now having a dialogue with the guys in Hamburg, and they're sending me back information about, you know, why you're doing it, but very happy to take the order. And they come up with plans for a range of augments, plans for extra small hinge, because again, your standard implants won't fit in these disastrous soft tissue envelopes. And this is what we came up with. After quite a few weeks of toing and froing, fixed hinge, augmentation, silver coating. And this is what it looks like after fixation. And there's a 12-month review. She has some tibial stem pain. I don't think that's integrated. And last week she blew a sinus and she's still infected.
Man.
So, do you know what? I think I'm clever. Do you know, sometimes I'm not. This is a case I haven't done, but is in the planning stage where we're thinking about putting an extra small fixed hinge, putting a augment on the tibia, using silver coatings again, and I haven't got through to do this one just yet. And it's becoming a dialogue. It's a two-way process. I send them information, they ask me questions back. It's not a question of just do it for me. They engage the surgeon. They absolutely have an understanding of what's important. And I'm sure other companies do this. I just happen to have done this work with Link. So my thoughts, I've done 6 to date. It's an efficient implant design and production process. It's a two-way process where you have to engage the company and have a dialogue. And, you know, and it makes the salvage cases just a little bit easier. Thank you.